I want to bring up to the podium Dr. Jay Pershad, who's the clinical chief of our emergency department at Children's National, who's going to speak to us about high value urgent care in our pediatric practice settings. Go, Dr. Pershad.
Thank you, Mark. As pediatricians, what does high value care mean? Fundamentally, from a patient perspective, it's better care at reduced cost. But what does it mean for us as pediatricians? What does it mean for you in a busy office practice that's seeing 15, 20 sick visits a day? Good morning to all of you, and especially those who are not here in person, but joining us via Zoom. It truly is a pleasure and a privilege. And to use Mark's theme, this is a shared learning type of opportunity. And just to be here and network after 2.5 years of seclusion, for lack of a better word, is truly exciting. I will, in that spirit, ask you to engage with me a little bit in a poll, because as we go along, I'm gonna ask you, so this is the poll. If you haven't really participated in it, you need to text 22333, and you need to text PNetworks 550. Once you sign on and do that once, then for the clinical vignettes that I wanted to engage with you on, it'll become a little easier. Just give you a minute or so. It's a little confusing initially, but the number you're texting to is 22333, and what you're texting in the body of the message is PNetwork 550. So value is quality over cost, is the traditional definition, but quality is providing safe, patient-centered, ethical, and evidence-based care. And that's where I want to focus on today, is share some clinical vignettes and focus on the current evidence that you can apply in your practice when you leave from here tonight. And then also the cost piece is we want to make it affordable and accessible for our patients. But when we do that, there's also a business case for it. You know you're accountable for HEDIS measures. Also, a lot of the contracts that are coming down the pike, and I know you're not a big fan of Care First, but they have a large patient network and covered lives. But value-based payments are becoming part of the contracts that you're signing right now. And you will get an additional payment if you can meet certain quality measures and if you can provide some financial reductions in terms of utilization management, avoidable ED visits, et cetera. So it's really important for us to keep up to date with some of this work. I'm going to discuss with you a few of these clinical vignettes, if you will, or clinical cases that you see in practice. We'll go through minor blunt head injury, community-acquired pneumonia, group A strep, bronchiolitis, febrile neonate, UTI, and sexually transmitted infection. So let's look at this first case here. You get a call from one of your mothers or fathers saying, I have a 23-month-old who fell off a trampoline at 10 a.m. in the morning. Your office is open. They hit their head. It happened about an hour ago. They vomited once. Mom thinks the toddler had a brief loss of consciousness. She didn't actually witness it. And now is back to normal, and they're in your office and you're evaluating them. I'm just curious what your thoughts are in terms of the next best step for this toddler. Thank you. Thank you for engaging on this. And the split is fairly close here between observing at home and referring to the nearest ED. I'm going to move on here. One of the tools that we use to risk stratify patients with minor head injury, really the fundamental question is, what is the risk of significant intracranial injury in this toddler, right? That's number one. Number two is, if there is a significant intracranial injury, what are my options? Do I need to scan them or do I need to observe them? And that's where the split is amongst us. So what we tend to use is, in 2009, the Pediatric Emergency Care Applied Research Network developed the PECARN head injury rules. And it's specifically designed to risk stratify children under 2 years, over 2 years. And this was a large validation study at multiple sites with excellent sensitivity and negative predictive value. And the reason I'm sharing this website with you, mdcalc.com, is because you can actually go through, it's fairly user-friendly, and it's good to use it for a variety of things. So let me give you a quick example here. So this toddler, I would just go to the website, it's free. I'll plug in my clinical scenario that I'm faced with. Was this patient under 2 years? I couldn't remember. Was it under 2 years? Yep, okay. Moving down, the first question that you ask is, were there any signs of, Betty, I may need a little bit of help here just to navigate down on the website.
Let me do this really quickly.
The next question you're asking is, was the GCS or Glasgow Coma Scale less than 14, or were there signs of basilar skull fracture? Were they, based on the exam, there was none. Hopefully you've done a thorough exam and there's no hemotympanum, there's no raccoon eyes, and there's nothing else going on. So if that answer is no, then the next question is, did they have any signs of severe mechanism of injury? And severe mechanism of injury is defined as a fall for more than 3 feet, or if there is a motor vehicle crash or a high velocity incident. Now, obviously the patient fell from a trampoline. So let's say the fall was from 3 feet. If you think this is a severe mechanism of injury, then the true risk of significant intracranial injury is 0.9%, which is 1 in 100. If we think this is not a severe mechanism of injury, assuming that the first two criteria are met, which is they're under 2 years of age, they have a normal GCS, they have no signs of skull fracture, then the risk is even smaller. It's 0.02%. So if that is the case, you're now wanting to discuss with the family. And here's where shared decision making and patient-centered approach comes in. And we use a tool and we talk to the parents.
Thank you.
I have two options. Either we observe the child, you can do that at home, especially in your case, you're part of the medical home. And if the patient develops any vomiting or persistent behavior change or is not acting right, by all means, you need to bring us to the emergency department. The other option is,
Dr.
we can
Pershad.
get a CAT scan. There's going to be some radiation risk. There is a cost to it. And you'll also pick up some incidental findings. We can go back to my presentation. And what we like to do, again, there's a nice tool from the Mayo Clinic that I want to share with you, where you can actually have this kind of conversation and go through the pros and cons and participate with them and do the shared decision making that you do every day with the families and decide if they want a CAT scan or not. And vast majority of these families, I can tell you, they will tell you that, you know, it's okay, we're going to observe them at home. You also have an opportunity to watch them for a few hours in the office if you'd like. But this table at the bottom that you can see is head CT. If you 100% certainty, you get a quick diagnosis now. There is radiation involved. You may pick up incidental findings, which is not something we can ignore. And then, of course, it typically is going to take longer. You're going to have to refer them to the emergency department. If you observe them, there may be a little bit of delay. There's no added cost. There's potentially a return to the ED. But in terms of actual percentages, you can go through MD Calc, and it gives you that tool that you can decide on what your risk is. Let's look at acute pharyngitis here. So you're seeing a 2-year-old with sore throat and coryza for 24 hours, is in daycare. There's no specific exposure. Apologize, the slide got cut off there a little bit. There's no exposure at daycare of any particular infection. Well, these days it's COVID, but exam, the patient's febrile to 39, has a clear rhinorrhea, has a mildly erythematous throat, has some shoddy lymph nodes in the neck, no rash. And what are your options here? Betty, I think it's I guess the question while Betty is pulling that up is really, what are your options? Do you want to test for group A strep? Do you want to check for COVID? Do you want to do a combo, which you, I understand, have now? Many of you in the offices have a tabletop PCR that you can do some of these screens for, or you do no additional testing. And if you know, testing for group A strep is part of one of the HEDIS measures, isn't it? Fascinating. I think that's the challenge these days, hasn't it? COVID has changed the entire dynamic. But what I wanted to focus on here is what is the risk of group A strep in this patient, which is really what we are talking about. If you look at the Red Book, if you look at the infectious disease recommendations, if you look at what's called low value care, is testing children under 3 years of age for strep, for group A strep, is really not value added unless they have a very specific exposure at home where my child has strep and I had strep, then it's a different story. Or if there's an outbreak in daycare. So testing them for group A strep, what's going to happen is you're going to pick up a lot of carriers. And you're going to be chasing your tail trying to treat them. So testing for group A strep under 3 years of age is low value. And you can see about a third of you are still interested in testing for group A strep, but perhaps you didn't have a choice. I didn't give you a choice. I locked you in for influenza and COVID. But these are some of the challenges. Now, do we test for COVID or not? I mean, that's a whole different discussion, isn't it? I think we'll wait for Dr. DiBiase to give us more feedback on this. But you can make a case for testing for COVID as well, or you can say this is viral. But what is also important is some of our medical assistants up in the front, when they check in with sore throat, are going to check for a throat swab. The challenge is we still need to do a careful examination because you can avoid that extra test, that extra cost, if they have vesicles on the throat. Like this child has clear coryza and cough going on. Or if they have some evidence of stomatitis, then you know they have a viral illness. So I think some of our processes we may need to reevaluate, and this happened in the emergency department as well. I mean, they're waiting, and the nurse is going to do a swab for strep because mother is worried about strep. But that conversation, I think, is going to be important. I think the children under 3 years of age, like we talked about. Let's look at community-acquired pneumonia here. So you've got a 3-year-old male who comes in with a fever of 39 to your office, is coughing, otherwise looks well. If you have pulse oximetry in the office, it's about 96%. And the patient is immunized and is otherwise healthy. So what are your options here? Are you going to get a chest x-ray? Do you want to prescribe amoxicillin for 10 days? Or do you want to maybe just give amoxicillin for 5 days? Or say, no, I think I need to really test them and do some more testing. Yeah. Fascinating. I think clearly, I think this patient has community-acquired pneumonia. I think most of you are in agreement with that. Has fever, has some lung findings, is coughing, and presenting to you. So the question is, do I test him or do I empirically treat him with antibiotics? And I think you're right. I think most of us have picked treating them with antibiotics. There's actually, if you look at low value care, testing community acquired pneumonia patients who are otherwise well, and you're not planning inpatient care for chest radiographs, blood work, is really low value care. I think you can empirically treat this patient who's fully vaccinated, and treating them with amoxicillin is very reasonable in this case. Actually, what's current in the evidence now is that and this is going to be coming down the pike, but most of us are now treating for 5 days. There have been several randomized controlled trials. They've got fancy mnemonics, CAP-IT, SCOUT, SAFER, but all of them are saying that the clinical failure rates and the recurrence at 14 to 28 days is the same with a shorter course of amoxicillin versus a 10-day course of amoxicillin. So you can change your practice and give them 5 days of amoxicillin in a patient of community-acquired pneumonia. And, if you think about it, trying to give our children antibiotics for 10 days, ourselves trying to take antibiotics for 10 days, the adverse reactions that occur, it's not something to be taken lightly. The other piece of it is most of them, if they're fully vaccinated, are going to be viral, let's be honest. I think that's a different discussion altogether, but we still need to cover for strep pneumonia. Okay. Let's look at UTI here for a minute. You have a 6-year-old girl with 2 days of dysuria and is afebrile, is well appearing, has some mild suprapubic tenderness, and presents to your office, and your choices for treatment are, do you want to give IM ceftriaxone, you want to give cephalexin for 3 days, you want to give something else like Ceftonir, or you want to give Bactrim for 7 days. And I think the correct answer here is cephalexin for 3 days. And the reason I say that is this is a patient with uncomplicated UTI, right? When I say uncomplicated, they're not febrile, they're not showing signs of pyelonephritis, they don't have CVA tenderness. And assuming that they're otherwise healthy, this is not a patient with recurrent UTIs, and we know there's no anatomic malformation. If they have obstructive uropathy from prior knowledge that you have, that's a different story. But this is a uncomplicated first-time UTI. I think using a low-cost antibiotic, when I say low cost, less first-generation cephalosporin based on our current guidelines from infectious disease for 3 days is sufficient for this patient. You can always extend it if the patient's not better, but there's probably not a good reason to jump to a third-generation cephalosporin like Ceftonir. I'm sure you can use it. It's nothing wrong with it, but 3 days and a first-generation cephalosporin is preferred. Bactrim is not, because of resistance to E. coli and some of the gram negatives that are commonly etiologies in our community. I'm going to speed it up a little bit because I'm getting signs that we're running out of time here, but bronchiolitis. Bronchiolitis, what is high value care and what's low value care? I think there's a lot of controversy here, and I don't want to, but what I want to share with you is the party line from the American Academy of Pediatrics as what is low value care in bronchiolitis and what is high value care. I don't think you can select multiple options here, but let me just be brief and say that other than suction and support, there's not a lot of evidence for use of any of these other agents. And you may not have a choice here. I think you can only pick one, but I think I'm asking for multiple choices here. But all the others, albuterol, racemic epinephrine, prednisone, even testing them for RSV and influenza. COVID, again, is a new player, but I'm not going to go there. But chest radiographs. In essence, frustrating illness, but you've got a happy baby who's wheezing, maybe with mild distress, who's not hypoxic. My suggestion to you is I think you're going to probably just counsel the family. That's what we would do in the emergency department, suction, supportive care. Now, obviously, if they need that next level of support, they're not feeding well, this is not working, then we would move to, we use high flow oxygen and we use non-invasive ventilation and that sort of thing. But that's a judgment call for you. Sexually transmitted infections. So I just want to touch on this briefly. You have a 16-year-old active female, a sexually active female with lower abdominal pain for 5 days and presents with mild lower abdominal tenderness. She's not pregnant, and a UA that you get shows some pyuria in there. What is the next best for treatment here? Do you want to get a cath urine sample in a 16-year-old, or do you want to have her self-collect a vaginal swab for PCR testing for gonorrhea and chlamydia, or do you want to just empirically treat her? Again, a fascinating breakdown here, but this is great. I think many of you seem to have the fairly rapid PCR turnaround testing in your offices. I see some head nodding. We don't have that capability yet. It still takes in the hospital, it takes, because it has to be batched. It's a tabletop machine. It doesn't come in a time frame that's conducive to a brief visit. So ideally, for antibiotic stewardship, you would want to confirm, because this patient probably has uncomplicated PID, maybe some cervicitis or urethritis going on. So the two options are either you empirically treat with IM ceftriaxone and azithromycin because you're covering gonorrhea, chlamydia, and then some other agents like Mycoplasma genitalium. So that's why you need to have those options. Here's the new evidence from CDC. The updated guidelines from CDC, the AAP, and the US Task Force for Adolescents is it's 500 of ceftriaxone, and azithromycin has been dropped. Your first choice is doxy because of increasing resistance for gonorrhea and for chlamydia with azithromycin. So your first choice actually is doxy with ceftriaxone. And then of course, part of your adolescent well child visits are, don't forget, they need screening for STIs if you're under 21 and you're sexually active. So that's the change. And hopefully the next future state is we're going to have this kind of handheld, quick PCR, which is already out there, that you don't need to batch, gives you a result in 30 minutes, and you can do targeted treatment for STI. Lyme disease, quick update. As you know, if you have a high-risk tick bite, we're in Lyme season now. In the past, we couldn't use doxy for children under 8 years of age. Current, hot off the press from CDC and Infectious Disease Society. If you have a high-risk bite, which is a bite that, the typical sunflower tick, over 36 hours of bite, you're in the season, you can give chemoprophylaxis with 1 dose of doxycycline, even if they're under 8 years of age. And then the febrile neonate guidelines, the reason I'm quickly telling you this is because this is what we've been, I know when I trained, anyone under 60 days of age with fever got a lumbar puncture and got admitted. But that age limit is being pushed lower and lower. And this recent guideline from AAP published in Pediatrics is actually a consensus statement with general pediatricians, hospitalists, emergency physicians. Bottom line is we're risk stratifying patients. We're risk stratifying patients using inflammatory markers, and we're deciding whether we need to do an LP or not if they're over 22 days of age, 22 days of age. 22 to 28, we're doing LP for the most part, but what we're doing more now is you might see us sending them back to your office the next day, either with or without a ceftriaxone shot, and they may be younger, especially if we feel that they have a good medical home like from one, your practices. And then finally, what I want to come back to this high value care business is to quote Don Berwick. He said, we really have good data that shows that when you take patients and you really inform them about their choices, patients do make frugal choices. They pick efficient choices better than healthcare system does. With that, before I do the takeaways, I just want to thank Mark Wiseman and the Future Pediatrics Committee for inviting me. I also want to thank you for your support of the emergency department. We're open and ready for you for all your sickest patients. I know it's been a challenging time all around for you and us as well, but thank you for your support. And this opportunity to collaborate and care coordinate, I think presents some unique opportunities. So I'm looking forward to maybe chatting with some of you through the rest of the day. I'm open for questions. And the quick takeaways, if you still want them, they're in the slide deck, but traumatic brain injury, don't forget the Pediatric Emergency Care Applied Research Network guidelines. Community-acquired pneumonia, remember short course antibiotics, 5 days amoxicillin is fine. UTIs, remember uncomplicated cystitis, 3 days of cefalexin is just fine. STIs, you have a choice. If you're treating them empirically, give them ceftriaxone 500 milligrams and doxy, not azithro. And if you're doing group A strep, low value for children under 3 years of age. For Lyme disease, you can do prophylaxis if they're under 8 years of age with doxy now. And bronchiolitis, frustrating illness, but just suction and support. And if they're well appearing, febrile 22 to 60-day-olds, we may not do an LP. We might say, follow up with Dr. Bogart the next day. She might not like it, but no, I'm just kidding. Well, thank you so much. It's my pleasure. Yeah.
Couple of questions on the Zoom. I'm not sure we're going to be able to get to all of these. So Dr. Pershad, if you're open, I may refer some of these after.
You bet, absolutely.
I want to
Yeah.
allow some time for our audience here.
I'm committed to answering all of them, yeah.
I think a question, very quick, what was the name of the tool utilized in the MedCalc website?
Yeah, it's called the PCARN, Pediatric Emergency Care Applied Research Network Head Injury Rule.
Thank you so much for a great presentation. I just have a quick question about the Lyme chemoprophylaxis. I know that we're not used to doing the young infants with the doxy. And how young would you go? Like infants?
I will confirm, Holly, but there is no age restriction there. I think the previous concern about teeth staining and all of that was with some of the older generation tetracyclines. So if you have to give one dose, I think you're okay. Now, whether under 3 months, 6 months, let me get back to you, Holly, on that definitive lower age cutoff, if you will.
Thank you.
Can I also just take a quick moment to acknowledge Holly? She served as an informal consultant to me for this talk, so thanks, Holly.
There's a question from our community audience about for pneumonia, does the research support 5-day courses of high-dose amox in all age quartiles?
Yes, indeed. Yes, absolutely, yeah.
I think for practitioners who've been doing this for years, even decades, for bronchiolitis, would you start albuterol nibs?
And I respect that question immensely because, we all want to do something, right? We all want to do something. And, there may be a small subset of patients. I will tell you what our order said in the emergency department is. What we've settled for is if they have atopic tendency, if they have eczema, if they have a very strong family history, not a distant third cousin, we're talking about parents or siblings with asthma, we might give them a trial of albuterol and say, look, if this works, we can send you home on an MDI. But in classic bronchiolitis, in an infant with wheezing, crackles, all of that, albuterol actually can be, there are also downsides to it. It causes VQ mismatch, their SATs drop, and you don't know whether you're just treating yourself or you're treating the patient. And so I think the answer to that question is yes, you can try. I think the guidelines don't say don't use it. It's just be thoughtful about it, I think.
And there was a question of clarification for the dose of amoxicillin for community-acquired pneumonia.
Yeah, it's high dose, so that'll be your 80 to 90 milligrams per kilo per day divided twice a day. So 45 per kilo BID. Yeah. Max, yeah, of course, there will be a max 2 grams. 2 grams BID, I guess, yeah. Right.
So Jay, I want to thank Dr. Pershad for sort of a spot on rapid fire mini case studies for the type of things that we see in frontline practice day in and day out. And you know, the rules and the guidelines that we trained with keep changing and evolving, and in many ways are less aggressive with more safety than how we, I think, originally approached things, which permits us to practice more cost-effective medicine. It does require us, though, to stay engaged and connected with our kids and families and make sure there's access to follow-up and ongoing care in case things aren't going the way we expect. Actually, before we break, Betty, can you come up here for 1 second? So all of us are in practice settings, and often something in the office or practice is not going right in the middle of busy mayhem, and every now and then we have to sort of turn to someone to sort of fix this so that we can keep the show running. Betty is the Chief of Staff for our Pediatric Health Network. But as you can also see, the Jack and Jill of all trades, and who's out here sort of helping, fixing things, and making sure we can sort of deliver this program to you in a polished, professional way. So let's hear it for Betty. Thank you for keeping us on track.